Okay, the time is 6:16 p.m. I have managed to get this done early, and I always record my first slide last. So as I'm going through, I can jot down notes and they'll let you know, hey, this is what you need to focus on. But the good news is I don't really have anything to add for you. So here's what I do have. You're going to do great. This is a good opportunity to bank some really good points. You know the recipe. Follow the recipe. Your apple dumplings are going to be on point. For real. Your sweet potato pie is going to be out of sight. Just follow the recipe and get going. Okay, so when we're talking about extraocular muscles, we're talking about the muscles that are responsible for movement along those three-dimensional axis lines. So horizontal, either toward the nose, which is adduction. And the way I remember it is I'm adding to what I already have within the core of my body, or away from the nose, which would be abduction. So the way I think it is, aliens are taking me away from, so I'm being abducted, versus adducted, which means I'm hugging something and I'm holding it close and adding it to my value and myself. Does that make sense? So vertical elevation or depression as well, or the movements that bring up the top of the eye towards the nose or away from the nose. Do you need to know that specifically? Yeah, you do, because these are common terms that you're absolutely going to be using for the rest of your nursing existence. So make sure that you understand the concept of that, because there is a point of contingency where I might say abduction versus adduction, right? The other ones I'm not so freaked out about because we use those well enough, but some of these I've never really heard very often. So adduction, you guys really need to know those two. So keep an eye on those and understand those concepts. The extraocular muscles are going to be tested specifically through the 6 cardinal gaze position test, or 6 cardinal positions of gaze is the technical way of putting it. And by cranial nerve 3, 4, and 6 testing. Those are basically a derivative of the 6 cardinal positions of gaze, so that's why they call that the standardized diagnostic comprehensive testing, versus doing those individual modalities of 3, 4, and 6. So when we're talking about assessment for glaucoma, we are doing a peripheral vision check because it is decreased in the patient who has glaucoma. And think about it, the intraocular pressure is so bounding, and it is so over encumbering that it's going to be a common problem of that disease progression. Because think about it, if I'm swelling that intraocular pressure, as I swell, I'm going to lose my field of vision, if that makes any sense, just because you can only hold so much and then you start dropping things, right? So what the body does as a natural reflex and defense mechanism is it's going to drop the least important component of that ocular vision itself, or that ocular acuity, and in this case is going to be that peripheral vision, right? Because I need to see what's straight ahead of me so that I don't trip in front of something, but the things on the side, they're kind of farther away. So I'm going to take the least invasive and then the most invasive last. So this is kind of why we have that progression issue. So confrontation test is what we use to assess the acuity of that peripheral vision. How well is that peripheral vision, or how poor is it? And we call it a confrontation test because I'm confronting and combating the idea of something is wrong, so I'm going to confront it head on, or in this case side on, by testing the level of understanding and perception that the brain has to that connection that it has with the eyes itself. Does that make sense? So the nurse is going to have the patient cover an eye while the nurse covers the opposite eye. Hold on, wait, does that make sense to me? The nurse will have the patient cover an eye while the nurse covers the opposite eye. Yes, and then the nurse will then bring an object to the finger slowly. So we basically have horse blinders, if you will. And we slowly move it to the frame of vision, and we kind of wiggle to promote movement so that the brain can conceptualize it a little bit faster. and we will do it usually midway between the patient and the nurse. And then when they are able to see, that angle with which they are able to see is going to let us know if that acuity is getting better or worse. So we will go in first and do a baseline, and then we will reassess, usually every 3 to 6 months. Sometimes it's a little bit farther stretched out if there's not really much of a change. Doctors do things kind of in heats, if you will. So when I first see a patient, I'm going to really hit hard assessments. I'm going to hit those assessments very frequently. And then once my patient hits a baseline that isn't changing much, then I increase that frequency with which I see them, or I decrease the level of appointments that I will give them in a year's time, right? So when I have a hypertensive patient, I will see them every 2 weeks or so in the very beginning. And then as I know that their blood pressure is corrective and still maintaining that correction, I will see them less. And why do I do this? Well, I need to make sure I'm as unencumbered as I can be. So if I see 100 patients a week versus 50 patients a week, that makes my life a little bit better. It works for employee retention, yada, yada, yada. If I know that my patients are okay and I stretch them out, it also helps them because then they don't have a ton of copays. They don't have to worry about meeting that deductible so much. So when we're doing nursing, I'm going to teach you guys how to think of nursing itself, but also think, how is this going to affect my patient? How is this going to affect my day-to-day, right? This is what I'm trying to combat now as an academic coach with 600 students. I'm trying to understand, how can I get the most reward for the least amount of time spent so that I can continue to feed myself, so that I'm able to continue to have this energy, frequency, and vibrational pattern that creates and promotes positivity. Same concept as a nurse, which is why nursing is multidimensional and multifactorial. Okay, so for visual acuity assessments, we use the Snellen chart for visual acuity. Basically, they're going to stand about 20 feet away from the chart. They're going to cover one eye at a time. We've all done that before during our physicals in grammar school. And sometimes in high school if we're getting like athletic permission slips. And we need to let the client know that they need to read the letters from each line, moving down to the smallest line that they can possibly read. What's important about this is as you go down the line, obviously, your ability to have better vision, quote unquote better vision, is going to be dictated by those smaller numbers, right? So when we say that a person has 20/30 vision specifically, that means that the patient is able to read at 20 feet what a normal eye can read at 30 feet, okay? So that's how I want you to remember this. So 20/30 vision, a regular person can read it at 30 feet, but I can only read it at 20 feet, okay? So that's the deficit right there. And that's basically all you need to know about Snellen chart, visual acuity. So make sure that you understand these concepts and then move on to the next slide. So when we're dealing with the assessment of the eye in the older adult, we need to understand that there are some expected findings that are pretty normal. So we're going to see decreased tear production, right? We're going to see arcus caeloneus, and we're going to see loss of hair. Most importantly, an unequal pupillary response, if you guys recall this in class, is the big deal we need to worry about because it is an abnormal finding. A lot of things can go on with this. Specifically, it's some type of trauma within the brain. It can be from increased interocular or intracranial pressure in the brain via hemorrhage, via a meningioma, right, or glioblastoma, anything that is pushing against that area. What's going to happen is your pupillary vision or your pupillary acuity or your response is going to constrict on one side and then vasodilate on the other side. So what we classically see is one eye is like 2 millimeters and the other eye is like 6 millimeters. And that is a problem. That is showing that there is a midline shift in the brain. And depending on which way we are shifting specifically is going to depend on, do they have the ability to swallow? Are they cranky and confused, right? It just depends on what side we slide. This is a medical emergency. This is of the absolute most importance. If I see an unequal pupillary response That is abnormal. I have got to immediately do something with that because there is increased intracranial pressure in the brain. And eventually, once we midline shift past 10 millimeters, at that point, we're basically brain dead. So it's a big deal that we watch out for those things. So that's the most important piece of this slide. Okay, so when we're talking about perforated eardrum assessments, this is a big deal. A perforated eardrum or tympanic membrane rupture, they're going to report severe pain followed by a severe amount of drainage. And I don't mean a little bit of what feels like earwax moving. I mean, you sleep on your pillow, you get off the pillow, there's physical drainage on that pillow, and the drainage kind of hangs out, right? We need to ask them specifically, have you had pain followed by drainage? It goes in that order. Okay, the pain is from the perforation itself, and then the drainage is everything evacuating from that area, kind of like a tidal wave. This is going to help you with your physician diagnosis as well, so that you can get them treatment faster, because when they hear, a physician hears, or a nurse practitioner or whatever, doctor of nursing practice, when they hear, yeah, they were complaining of pain followed by an immediate amount of drainage and it's copious and yada, 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 they go, oh, okay, I know what to do, right? So this is going to help our patient out without him hauling around and paying for additional testing that doesn't need to be done. A tympanic membrane rupture is associated with infection more often than not. Change in pressure, so like if you get on a plane or if you drive up into the Tennessee mountains, or self-induced trauma. Okay, so I always tell the story about keys. I had a car salesman who I kept a relationship with for a while, until the day I went to sign on a vehicle and he was literally digging the key into his ear to clean it because it was itching, and I nearly just lost my mind because the first thing I thought was, did he stick that in my car? So keep that in mind. In self-induced trauma, change in pressure or associated with infection is specific to tympanic membrane rupture. Routine hearing exam is done for screening of hearing loss. It is not associated with the tympanic membrane rupture, so please understand that. Ringing in the ears, however, is associated with tinnitus and not rupture. So a lot of people will think that they're all concomitant with one another, like they all are a part of the same perspective, and it's not. This is something completely different. Ringing in the ears could be from sensational loss or neurosensory loss over time. It could, due to aging. It could be that someone pushed a whole bunch of Lasix in them way too fast, and then they've got ototoxicity. Like, it could be a whole bunch of other issues. They could have a bug in their ear. I've seen that one before. So it solely depends. But what you need to understand for sure is the concept of making sure that we report the information as evidenced by the patient's subjective data that they had pain followed by drainage. And that is exactly what we need to let that physician know, because that triggers them to start that assessment and to start that disease process recovery. Okay, pediatric ear assessment. So there was a little bit of confusion, so I made it a little bit easier for the purposes of the general consensus of how this works and for the purposes of the examination. So the assessment includes using a tympanic thermometer, which has to be placed in the ear, right? So how do we effectively do that without A, hurting baby, B, ticking off mom and dad, or grandma, whatever that looks like, and C, we get an effective measurement of that temperature, right? So for children who are under the age of 3, the nurse will pull the pinna down into the back. For children 3 and older, the nurse will pull the pinna up and back. So how do I remember this? All right, well, the way I think of it is 3 and older means we're going up, and I pull the pinna up and back. If they are 3 and under, I'm going down. Under means down, lower than. So I'm going down and to the back. So there's your hack for that one. And we'll move to the next slide. All right, so sensorineural hearing loss, may be caused by presbycusis, which is the gradual damage and degeneration that happens with the normal aging process, or ototoxicity via Lasix, which can affect the hair cells and the cochlea, which is what is the receptor. So the hairs basically pick up the vibration and move them along, much like your villi and your microvilli of your intestines move the poop along, right? Same concept, except for we're just listening to frequency and vibrational pattern within that speech. So it will move it along the way, and it will then send the information to the cochlea for the reception of that speech. The nurse needs to ask the patient specifically about the medications they've been taking. The reason we need to do that is if they're concomitantly or predominantly on Lasix, that is going to be a trigger for us to let us know maybe this is an ototoxic issue and maybe we need to change those medications out, right? A simple increase in amplitude is not going to necessarily enable a person to understand spoken words. Remember, if you don't have any hairs in your ear, you can't transmit that information to the cochlea. This is like, how could I define this? This is like, oh yeah, cool. So this is like going to Kroger. And what I do is I put all my groceries at Kroger on the conveyor belt. And if the conveyor belt is broken, I'm not going to get the information over to be scanned so that I can take my groceries home. Same concept. The middle ear and obstruction of the external ear, they are not associated with sensorineural hearing loss. So we should not assess for a middle ear infection or external ear obstruction if that is the case. Please understand that, because sometimes we get it twisted and sometimes people believe that that is the cause of that, and it could not be farther from the truth. So we need to ask our patients about medications they've been taking. We need to understand that this is a gradual nerve degenerative process via aging or ototoxicity, and then it's going to affect the cells, the hair cells within the cochlea to process and transform and transmute and disseminate that information or that vibrational pattern over for speech reception. All right, so smoking assessment, this is pretty straightforward. Smoking history, hey, guess what, guys? This is just the most compound, abstract concept in the world. This is revolutionary even. Respiratory conditions such as lung cancer are increased in the smoking patients. So when we're collecting a health history, we need to find out what their smoking history looks like. How many pack years do we have, right? How long have you used tobacco products? How willing are you to quit? Because if someone goes, I'm not going to quit, should I waste my time? No, it's not going to go anywhere. What I can do is educate them and let them know, hey, listen, this is coming your way, but they already know this, right? Like we all know, in certain countries, they will, when you buy a pack of cigarettes, they will have lung cancer, or they will have an exposed lung with cancerous cells and cancerous malignancy on the side of the pack. I cannot make these things up. It's a real thing. It's a literal picture on the side of the pack to remind you what you were doing to yourself. And it actually, in England, they started doing that probably 2002 when I was living there. I don't like to admit this, but I did have a smoking issue back in the day. And it is what it is, right? Like some of us are raised in areas where that's perfectly normal to smoke in the house with little babies running around because that's the cultural narrative. So how could you be angry at a person for doing exactly what they were taught to do from, a young childhood perspective? It isn't until you get older and you get out there and you realize who you are as an individual and you find your true north or your true self that you look at things and go, that's not exactly how things should have gone, and then you correct it, right? So education is how we do these things, and we can educate them and let them know what's going on. But if they don't have a willingness to quit, it's not going to go anywhere. You're only going to tick them off. And we don't want to tick off our patients. We want to ensue and foster trust in a relationship, right? This is a relationship that we deal with when we have our patients. They tell you not to care about your patients, or at least they did for me when I was in nursing school. That is the dumbest concept I've ever heard, to not care for your patients, because what's the whole point of having a patient if you're not supposed to emotionally be available for them, right? Emotional availability is more important than physical healing sometimes, right? Sometimes you can't fix them. Sometimes they're dying. But your emotional availability and you fostering and feeding their emotions rather than clouding and walking away from it, it gives them the greatest gift that humankind can give another person, and that's hope. The idea of hope. The idea that I can hope to be happy one day is more important than anything you can ever purchase for me. I can't be bought. I can't. I can't be bought. I will never be bought. What I can do is I can instill hope in another individual, and that hope is enough to move a mountain. It's enough to lead a nation of broken people. It's enough to form a legion that will fight and die for you, for what they believe in and for what they stand in. You have the ability to instill hope every single day, and that's what we need to do, because that is more precious than gold itself. So, while we're talking to them and we're defining what their willingness to quit is, we also need to evaluate that the client, what they've done in the past to try to quit. Sometimes they do want to quit, but they get frustrated and tell you they have no intention of quitting because they have tried these things and it's been unsuccessful. So we got to dig a little bit deeper and figure out exactly what's going on. We have to do what I call a mini psychological profile. Why are you the way you are? People aren't inherently angry people. People aren't inherently malicious. You don't wake up out of the womb one day and go, I'm going to trip somebody because I like the idea of breaking their nose. No. Something has hurt you. Something has tormented you. Something has broken you into feeling that it's physically okay to hurt somebody else, because somehow that validates your existence. And what we need to do is recognize that and not get angry with it, not get mad at it, because all that's going to do is foster that wrong way of thinking, and it's going to stop any corrective action that you can take with that individual. No, what you need to do is dig into it. Show them that you care. If people know that you care, regardless of what you say or how you say it, they're going to give you grace. You guys give me a lot of grace, and you know I have a lot of things to say. But because we trust each other, and you know that I'm nothing but good intention and I have no ill will in my body, you will let it slide, and I will do the same, right? Because that is what a relationship is, and this is what we need to foster within our patients. So make sure that you evaluate what the client has done or what the nurse or the patient has done in the past to try to quit. We simply ask, okay, what have you tried so far to quit? And then we just sit back and look. We need to be attentive. We don't need to look at our shoes. We don't need to look at a computer like we're just trying to, collect data. We need to look at them in their eyes. We need to look into their soul. We need to say, what have you tried already? And we need to do it with an empathetic manner. Turn your head to the side. Look at them and focus in on them. Squint your eyes a little bit. That lets them know that you're trying to do a deep dive into their mental process, and people appreciate that. People inherently want to be wanted and need to be needed. I am proof positive of that. I want to feel validated in my life by fostering other people's development. That's why I was born. That's what I'm here for. That is what I'm going to die doing, and I'm happy to do it. You guys feed me energy by you guys receiving my energy. Much like, in order for this planet to survive, we have to breathe air and we have to extinguish and expel carbon dioxide so that we can feed the very plants that provide us with oxygen. We're all connected. It is a dance and a circle that is magnanimous and is infinite in its understanding. And without one, you cannot have the other. It's the yin and the yang of entire human existence. So keep that in mind. Ask them, what have you tried to do so far to quit? And look at them with concern and compromise in your eyes. Because I know you guys had to know how to do that, especially with COVID and wearing masks. Show them that you care, and they will sing like a canary to you and give you everything you need to know. Okay, so COPD assessment. This is pretty standard. You're going to see this, and if I had to guess, I'd probably say 40% or more of our population has COPD, especially when you get into your more Appalachian areas, Appalachian, tomato, potato. So when you get into these areas, a lot of people smoke because, again, this is the old way of doing things. Some people know that it's going to cause problems, but some people are also of the idea that you got to die from something, right? So we have to be, not appreciative, that's a terrible word. We need to be cognizant of that, and we need to show empathy, not apathy towards that, because I say this often because nurses have a bad habit of playing the I'm the best nurse in the world game. I know the most things about the most things, and what I say is gospel, and that's cute and all, but that's usually the mark of a brand new nurse, because you'll find that the nurses who really know what's up and have really dug around in the trenches quite a bit, those guys usually keep it quiet. They don't throw their accolade around because they don't really care, because when you have been transformed into somebody that sees death and that sees loss and that sees pain on a daily, you don't need to prove yourself to anybody. because PTSD is a real thing and it's a real problem within the nursing field. You need to prepare yourselves for these things. So with COPD assessments, they're going to have overinflated lungs. It's going to result in a 1-to-1 or equal anterior-posterior to transverse diameter ratio. And what this means is I am as far out as I am as far to the sides, right? The abnormal AP diameter results in this barrel chest appearance, which is like a circumferential appearance. It's very wide. It's very bizarre looking. These guys are usually very thin. You can see the muscles in between the intercostal spaces of your ribs. It's quite terrible to watch. And at that point, it's a little too late. These guys will still smoke. And again, don't throw your judgment on them. Don't pass that on them. If you are in a position where you are reliant on oxygen, how would that make you feel? How does that make a person feel to know that every time they go to Walmart, they've got to strap an oxygen tank to them and have little kids walking by point and stare at them, and their moms and dads don't stop them because, you know, they're off in their own little world doing their own little thing. This is the reality that we live in. This isn't textbook. This is just gospel. This is what happens in the world. So we have to be appreciative of that. We have to be aware of what that must feel like to be that person. So who in the heck are we to judge somebody for smoking a cigarette, because the stress and the embarrassment of going through that is going to cause them to have an anxiolytic trigger that needs to be soothed. And guess what does it? Nicotine. And the act of given their satiated balance by way of putting something into their mouth, dragging back on it, and feeling a sigh of relief. Most of this is a psychosomatic process. The idea of being addicted to cigarettes is not because they want that nicotine, because we have found studies where we just have water replacement and nothing that's a nicotine source in there. And other than the first 3 days they're a little crabgrassy, they're fine beyond that. And it's because it's that soothing mechanism, like a blanket for a baby or a bottle for a baby, that helps them relax. So we need to understand that that's where they're coming from. We need to educate them, hey, don't do it with oxygen if you're going to do it. And we need to be their biggest cheerleader, because when we decide that we know better than somebody else, that's when we create complication in our world that's absolutely unnecessary and is not going to foster any development in a person. Our whole purpose on this world isn't to tell somebody what they need to do right or how to do it right. Our whole purpose in this world is to let people be. Simply be. Whatever that is, in that moment, we need to love them and understand them and try to help them with their own progression, with their own exemplification and understanding of their own embodiment in this human existence. It is not our job to tell you what to do. It is our job to give you the information and let you decide. That is the definition of true freedom, okay? So, barrel chest appearance is going to be the absolute 100% caveat with these guys. Make sure that you understand that it is normal for nasal flaring. It is normal to see respiratory distress in these guys. So it is normal for them to live in 88% SpO2, right? If we over-oxygenate them because it's overinflation of the lungs, they're not going to be able to expel that CO2. They're going to get respiratory acidosis if we if we over-oxygenate them. So you have to be very cognizant of that. These guys are going to get really, really crabby, and then after they get crabby, they're going to get confused, and you're going to know that you've already done something wrong, okay? You'll get the hang of it. Don't worry about it. Clients with COPD, they have enlarged neck muscles. Again, we are forcing our need to breathe. And when I force my need to breathe, I am overworking those muscles, much like a person has cardiomegaly, right? They do it because the heart demand is so great that the heart literally gets larger like a bodybuilder. Same concept. It's just with their neck muscles, because think about how it is to breathe. Go ahead and give yourself a breath right now. All right, did you feel those neck muscles you just used? Same concept. It's like doing that, but all day, every day, just so you can get a gulp of air. It's that serious. So people who have no COPD or any of those pre-existing conditions will have a 2-to-1 diameter. So please understand that a 1-to-1 is not good. It is a circumferential or barrel chest versus a 2-to-1, which is usually going to have a disproportionate ratio. Okay, so let's talk about respiratory distress, specifically stridor. It is an abnormal assessment finding. It is unexpected. It is a medical emergency, right? So stridor is done during inspiration. It's done if a kid chokes on a cert or has an asthma issue sometimes. A lot of times it's epiglottitis, things of that nature. Something is constricting the airway. We have got to a lot of times intubate this patient. They're going to have a higher respiratory rate of 28 or above. Your pulse ox is normally going to be fairly okay, right? We're 92, but 92 for a babe or for an average person when they're used to being 100 is going to overexert them, obviously. This isn't like a COPD patient. So it's going to decrease your tactile thermitis, their expected findings for someone reporting shortness of breath. Now, what I'm going to do really quick is I'm going to play you this sound bite. Hopefully you'll be able to hear it, because once you hear it, you're never going to forget it. So I'm going to play this really quickly just so you have an understanding of what it sounds like so that you can then correlate it later on in life if you need it.
In this lung sound video, we're going to discuss stridor. Stridor is a type of inspiratory wheeze that is typically, and it's something that we often refer to in children because it's more commonly seen in them. They can produce it with conditions like airway obstructions or croup, epiglottitis. And the key thing to remember
we're stuck with this for a second.
Lung sound is that it's going to require medical intervention, oftentimes on the quicker end of things.
All right, so if you guys ever hear this, do not pass go. Do not collect $200. Go get somebody immediately, and that somebody should be respiratory. Call your doctor second, okay? All right, so here is the gambit of what we have. When we're dealing with pneumonia, we can actually hear the sounds and know, as you go along in your nursing career, you'll be able to hear the sound and know basically if it's pneumonia versus pulmonary edema versus asthma versus pleuritis versus like a narrowed airway because of a respiratory obstruction of some issue or some sort. So coarse crackles are what they call rhonchi. They're low-pitched gurgling sounds that clear with coughing. They're commonly heard with pneumonia. So when we have a patient with pneumonia who's been laying in bed for a long time, we always tell them, give me a cough, because it does one of two things. One, it clears the airway so I can actually listen to what's going on, right? And then number two, it helps them with their coughing and deep breathing so that we can try to open up those alveoli, those little balloons that the clown is holding that makes up that lung tissue, right? So we do that because what happens is when you have pneumonia and you're laying flat, everything kind of settles. I know you guys have had some kind of sickness, whatever it was, seasonal allergies, yada, yada, and you're laying flat in bed and you cough all night. It's because it has nowhere to go. It wants to expel from your body, but because you're laying flat, it just falls right back down. This is the same situation with a patient with pneumonia, only it's, times 10. So we're going to hear those coarse crackles. Just have them clear it really quick. Low-pitched gurgling sound. And again, coarse crackles are concomitant with pneumonia. Fine crackles. They're a little bit different. Fine crackles are low-pitched and they're moist. That was not an example of that if you guys heard that. That was Professor Novak coughing in the next room over. So, low-pitched, moist sounds that indicate there's fluid in the lungs. Now, this sounds completely different. You can hear this from the hallway. This is associated with pulmonary edema. This is a problem, obviously. Wheezing is high-pitched musical sound. Remember, when I discuss high-pitched sounds, energy, frequency, and vibrational patterns like I always do, remember, anything that's high-pitched means uh-oh. Much like a ventilatory alarm that is high-pitched means that something is occluded and a person is going to die, right? When we hear high-pitched musical sounds, that is like our ventilatory alarm, and that's already encoded in their DNA for a human being. It is done this way because through classical conditioning, through evolution, we have learned that parents, adults, whoever's around is going to recognize that high-pitched frequency with that moist sound, and we'll think of it as an emergent reaction versus a low-pitched sound, which is why people will have coarse crackles and rhonchi for weeks, and everyone's going to be like, meh, whatever, no big deal, okay? So just remember, if it's high pitch and it's musical, it's usually associated with asthma because something's in the way or we have a narrowing of those, a narrowing of that airway, which is a big problem. Friction rub is a coarse, low pitch grating sound. And let me see if I can do this. You ready? That's what it sounds like. Only it's like if I rub two pieces of sandpaper together. I don't think I have any sandpaper in my office. I might. Ha! Wow. Leave it to Molly, right? You ready? This is what it is. That's the sound you're going to hear if you were able to hear that at all. If not, you can always just YouTube it. It's no big deal. But when we hear that, it is usually a result of pleuritis. Remember, this is the thing that pleurisy is what I'm terrified of because it's literally the grating of that pleural sac that is inflamed and it is rubbing up against in a very hard way. And it's incredibly painful. It's probably one of the more incredibly painful things that I think I've ever experienced, and I've experienced quite a bit of pain, to be fair. Stridor, we talked about that. Sharp scraping sound. And this is a narrowing of the upper airways, so make sure that you say stridor is upper airways. And it's, like I said, sharp, and it's kind of, here, let's see if I can do this. I think this will work. You ready? Minus the metal ting that you just heard at the very back end of that sound, same difference. And again, YouTube it if you're really concerned about what those sound like. I would encourage you to do that because you do need to know these things. So just make sure that you understand what the sound is, what it's called, and what disease process it's commonly associated with, and you should be fine with this slide. All right, so now we're going to talk about vesicular breath sounds. Vesicular breath sounds, they're soft, they're low pitch. You can hear it throughout the lungs. Usually it's during inspiration. They're normal, but some abnormal sounds can happen if they have like a chronic condition like chronic bronchitis, or if they're like hardcore asthmatic, or if they have seasonal allergies. Sometimes you can hear it. I'm going to play you a sound bite. I've already fast forwarded it past the guy talking. Hopefully it's going to work. I can't promise you anything. But they're heard over the peripheral lung fields, and that's the most important piece of information that you need to know. And as much as I want you to know what an abnormal sound is, I need for you to understand a normal sound, because sometimes it'll trip you up and you'll think it's something that it's not. So here we go. All right, so that's a vesicular breath sound. It's normal, and again, this is usually a person who's got a little bit of wear and tear in their lungs, so it's not going to be, perfectly clear. And again, no big deal. What you need to know is it's normal, it's soft, low pitch, it sounds like what I just sent you, and it's over the peripheral lung fields. All right, auditory deficit behaviors. Presbycusis is the most common one. Presbycusis. Presbycusis. Either way you want to say it's fine. It's impaired hearing due to aging. It's completely normal for a lot of people. It's basically a sensory deficit that alters their behavior and ability to accommodate for that deficit. So what we're going to classically see is a patient usually turns one ear towards the person that they're talking to during conversations. They usually also squint their eye a little bit, or they'll give you the occasional and that will give you the indicator that you need to talk a little bit slower, talk a normal pitch, not high pitch, like, hi, can you hear what I'm saying? Nobody needs Minnie Mouse trying to talk to them. It's annoying, okay? So just use lull tones, kind of ebb and flow with your speech. You don't want to speak kind of like how I normally speak, which is a little bit faster, especially when I get excited. Make sure that you understand that they're going to avoid others sometimes because of the sensory deficit. We need to let them know that that's maladaptive. That's not going to do us any good in the world. That's actually going to foster their ability to be a little more depressed, because at this point I have reinforced the fact that I have a problem as far as society is concerned, and because of that I'm not going to be able to fit and conform into societal norms. Okay, this is why I constantly talk about having Asperger's, because I have zero shame for what I am, much like a person with a sensory deficit needs to have zero shame within them, because they're not going to be able to be who it is that they're supposed to be in this world if they're too busy hiding in the shadows and worried about what everyone else is going to think or say or make fun of. Okay? So let them know. Put yourself out there. It's okay. What I need for you to know for this slide is what presbycusis is. Is it normal or not? What is it common in? What type of patient? The elderly patient. And you need to know that they're going to turn one ear towards you, and that is a direct indicator that that's what this patient is experiencing. And we need to educate them and let them know avoiding others is not the answer, right? There's nothing wrong with who you are. It is the way you are, and you need to get what you've got and make the best of it, and it's fine. No big deal. Okay, so sensory alteration assessment. As we age, things change in our eyes. It is what it is. This is why I don't like the word ageism, right? Because at some point in time, we decide that because someone needs corrective vision because they can't drive past 7 o'clock at night because it gets really rough for them, we automatically assume that they're old and tired out and they've got nothing else in this world to give. This is a Western societal problem. I don't understand it. I never will, because where I come from, the older you are, the more valuable you are. So you cling on to people who have aged gracefully with the grip of a gorilla holding a banana they're ready to eat, okay? This is how we need to treat people in this world, and I don't understand why we don't, but they're going to have night vision issues. Their night vision is going to become impaired because of the physiological changes that's happening to their body as aging occurs, right? Remember, as we age, our cells start to die. It is what it is. As we age and our cells start to die, our defense mechanism through evolution and millions of years of human existence, as far as science is concerned, we are going to take what we can get and keep hold of what we can get that's most important. So what is less important? Vision during night, right? Most people are at home. Through evolutionary process, we know we're safe when we're at home, okay? So during the dark times, it's going to get a little bit darker, and it's going to get a little bit starrier when you see headlights, and that's scary for a lot of people because sometimes those headlights are so bright, it breaks off in a starburst and you can't see in front of you, okay? Older adults lose the ability to distinguish high-pitched noises and consonants. That is also completely normal. I always joke that I had a teacher who I love very dearly who told me this in nursing school, and I said, all right, fine, I'm going to take the Pepsi challenge. So I may or may not have recorded on a PowerPoint slide, much like I'm doing right now, me repeating a word that I'm not going to repeat to you guys over and over and over, and I dubbed over it a high-pitched frequency through auto-tune as if I were T-Pain, if you guys can remember who that is. That aged me, I think. And I played it the entire class, and through 36 nurses in that class snickering for the last hour and 45 minutes of that class, she just looked on like we were nuts. And it was a great moment in time, and it was a great joke that when I see nurses that I graduated with, we talk about it almost immediately. And it was all in good fun, and I told her later on about it, and she rolled her eyes because she was the greatest teacher ever. She was a Wright State. So yeah, that is a real thing. I'm not going to tell you what amplitude I use, and I'm not going to tell you what frequency I use because I'm not going to let you do it to me because I'm not quite that old, so I can still hear everything from about 180 paces away. I actually have really great hearing. I just don't talk about it because I don't want you guys to know. I don't want you to know. So make sure that you understand high-pitched noises and consonants is going to be a problem, which is why you hear people who are in the aging process say you're mumbling, right? Senses of smell and taste are also decreased with aging. As we age, our need to have satiation, our need to feel like we are comforted with food goes away because we have bigger things to deal with. We got bigger fish to fry, pun intended. So I'm not so concerned with food because food now is fuel to me, whereas food before used to be mom's home cooking. Who am I lying to? Mom never cooked anything, right? She had servants. It was dad's cooking, to be fair, and grandma's cooking. Oh, grandma's cooking was amazing. She had the best chicken in the world. So make sure that you understand these concepts. Night vision, impaired because of physiological changes with the eyes, high-pitched noises and consonants of the ears with the older adult, and senses of smell and taste. We don't care so much about it. We're just trying to feed our body and get moving. Okay, so specific to aphasia and communication, because a stroke is usually the cause of partial complete paralysis of one side of the patient's body, they're going to need a special assistive devices, and this is a concept that we need to understand. When we have partial or complete paralysis of one side of our body, we have to have a special assistive device. We should include interventions in our care plan to help the patient adapt to this deficit while still maintaining their independence. Remember, just because they're down doesn't mean that they're out, okay? They're not down and out until they say they're down and out, and this is how we need to treat them. We don't need to coddle them unless they request to be coddled. We need to treat them with dignity and understanding. The demons that are going on inside of their head and their battle that they're dealing with, it is magnanimous. It's huge. We can't even begin to define what that must feel like. So we need to ask them questions like, what's going on in your head? How are you feeling right now? We need to let them understand that we have no words. Sometimes nurses are really bad about giving advice that doesn't matter, right? Classic example, I've just miscarried a baby. That's okay, you're 23, you can have another one. How dare you? How dare you tell me how to feel? How dare you tell me that it's okay that I've just lost and I'm grieving? How dare you tell me that I'm going to go get over it? You have no idea of the person I am, nor the caliber or integrity that I keep, okay? So we need to make sure we're very, very careful about how we place these comments. We never want to give somebody half-hearted advice or half-hearted comments, because at that point you've lost your patient. You've lost your patient's respect. And I'm telling you, as I get older, I realize the only thing that truly matters in this world is the respect that I keep on my name. That's it. Because when I'm dead and gone, the only thing that's going to stay around is my reputation. And that's all that matters to me. That's it. Nothing else does. Because at the end of the day, you are going to be either in a favorable way or you're not. And what matters is the company that you keep and the legacy that you leave behind when you're gone. Nothing else matters. Nothing. Literally nothing. All the other ins and outs that we fight and squabble over doesn't matter. It really doesn't. It doesn't dictate who we're going to be when we're no longer on this planet. So we need to be receptive and mindful of this. And we need to say, how are you feeling? What's going on inside of your head? That's a common question I ask. Tell me what's going on inside of your head. This is an open-ended question. This is going to, with the trust that I give them over time and the trust and bond that we receive with one another, I'm going to get more information. And this is going to give me the ability for a person to open up so that I can foster them with solid advice and solid solutions. So part of that is your nursing intervention. You guys always know I talk about the mental process and I hammer it until it can't drive any farther into the core of the earth, right? And the reason that I do that is because it's that big of a deal. If I'm not instilling hope in you, why am I here? If I'm not giving you the drive to try another day instead of quitting and packing it up and being done, why am I here? If you are not influencing another person on this earth and all you are doing is degrading them and dropping them down to their knees just because you can, your purpose, there is none. What your purpose has become is to spit venom in the direction of a person who is a wholeheartedly good person. And you've done the exact polar opposite of your contribution to this planet. So we don't want to do anything to hurt these people. Teach them to use assistive devices. Allow them to care for themselves. Don't coddle them. Nurses are really bad about doing something because you can do it fast, right? Like I can change a patient in their bed that's paraplegic in my sleep, right? I can turn over a 600-pound patient because if you cup them at the acetabulum and cup them at the glenohumeral joint or the shoulder area, you can scoop them over. It doesn't matter how heavy they are because the body will go wherever those bone pieces go because those are the core pieces that connect the body to itself, right? So that is the relative north and south of that trunk. So if you shift it in any direction past 45 degrees, it's naturally just going to roll on its side. So I can do this in a matter of seconds. Every PCA that's listening to this right now can do this in a matter of seconds because we just have got the technical skill to do it. What we're not doing when we do these things, though, is we don't give them an opportunity to fend for themselves. And if we teach somebody that they don't have to fend for themselves, guess what? We create our own complication in this world, and we have taken the human dignity and soul out of a person. And you can see it in their eyes. You can see the shame in their eyes. And the patient didn't create that shame. You did. You created that shame. You spent all of this money to get all of this education, to be a nurse, and to conform and be the hero of society itself. And what you've done through your own arrogance, through your own inner hostility with your patient load for the day, is you have taken a piece of them to the point to where they have become broken eternally. And you can see it in their eyes. They're helpless and they're hopeless. Instill hope, instill faith, instill the ability for them to keep going. You are harnessed with that power. It is a power that you can use to rule a nation or to burn it down to the ground. So make sure that you're doing the right thing at all times. It's hard. It's hard to do the right thing all the time. I mess up all the time. But if I correct myself immediately, then it's okay. All right? We're not perfect. Nobody's perfect in this world. No one's ever going to be perfect. And the people who pretend they're perfect are the most perfectly imperfect people. So don't let them get to you either. Because you're going to have nurses that are going to drag you down for caring about people. I have nurses all the time that tell me, why are you doing that? You're making my job harder. Good. I'm glad. Wake up. Wake up, tenured nurse. You need to do your job. You need to try. You need to try to instill and foster hope in other people. Okay, I'm done with that little spiel. So make sure that we're teaching our patients to use assistive devices to allow the patient to care for him or herself. Give them autonomy. That's what this is all about, is creating autonomy within a patient. Make the patient talk. Make them understand that making them talk sometimes can be inappropriate. It can be demeaning, but we want them to talk and share while we're fostering a developmental bond, okay? So this is something that we back off on in the beginning, right? And once we get close to them, and once we make them laugh, and once we have their grace and their favor, then we would do that. But in the initial, all we need to do is teach them how to be themselves and be autonomous in whatever it is that they're dealing with. Home health nurses, please know that they're not necessary for the patient if they're able to care for him or herself. A lot of times we will make a person feel like they're sicker than they really are if we bring in a home health aide that is unnecessary, and that ticks off a lot of people. That would tick me off. I'd be angry about that. What, you think I can't do things myself? Seriously, come on, man. So make sure that we're doing the right thing. I understand a lot of people want to help out other people and give them these resources because they might not necessarily have them, but let them give themselves their own shot first, please. Don't put a patient on antidepressants if you can stand it, right? We don't want to chemically change their brain because they're going through a bad situation. We want to chemically change their perception of whatever there is damaged within their body process. And we chemically change them through transmutational neuroscience, right? I'm instilling power, empowerment, and positivity in a person, right? Antidepressants won't do that. Antidepressants will just make you not feel in the beginning. And there's a lot of side effects that go along with it, especially when you're dealing with post-stroke and you have medications that you're going to have to make you bleed a little bit more. Sometimes these can mess with that. It can raise your INR. We got to be really cognizant of all these things. So don't just think that a pill is going to save the day, because I know plenty of people on antidepressants that are still just as miserable as they are on the highest dose that they can be on, and it's because the doctor spent more time writing them a script than he did looking at that patient and going, what can I really do to help you? So you have the ability as a nurse to do that. That's what makes nurses amazing. That's what makes you a tier above the rest, because you have the ability to actually foster hope, development, positive change, positive affirmations, and they believe us, and they should, because we should mean it, and they're going to know the difference. So do the right thing. Assist the patient in attempting to adapt behavior to the sensory deficit itself. Positive empowerment is how we fight this fight, okay? Make sure that you understand we need to have special assistive devices for them to accommodate their paralysis. And then I think we should be good with the slide. Okay, So when we have impaired vision patients, which happens more often than not, usually they have near blindness or total blindness that's legal, which means that we need to do things to help accommodate them so that they can communicate with us more appropriately. Obviously, putting like a sticker, or we used to use an electrode on the nursing call system so they can feel that bump on that electrode that would clip in normally, so that they can let us know when they need assistance. Things that I hate that I added on here: using family members is not, or repeat, is not, one more time, Nikola Tesla, is not the best option. It is annoying. It is aggravating. A lot of times they never articulate what the person needs, and they either underestimate it and say, hey, they need you real quick, they have to use the bathroom, when they've already had an accident in the bed, or they over exaggerate it and they say, he can't breathe, and then we go running in there and he's fine. He just is, maybe needs a position change, and we have ran in people unnecessarily. Making hourly rounds is not sufficient. It's just not. The nurse needs to make sure that they can get in touch with you anytime, and I think that's for obvious reasons. I laugh about this. So someone actually color coded the nurse call system. Oh God, I can't even begin to tell you how much time they spent color coding it, because they saw in the dynamics in the history and present illness that the patient had total legal blindness, but could see colors adequate enough. And they took that as, okay, if I get really vibrant, bright colors, that's going to trigger them that that's what this is for. And they made a color coding system and basically colored with markers the call light system. There's two problems with this. One, seriously, why? Two, what happens when you wipe a crayon or a marker and you wipe and swipe over the same area over and over? Oh yeah, that's right, it goes away. So this is the other problem that we have with that. So most important factor is make sure that you place a sticker on the nurse call system to allow the patient to page the nurse when assistance needed, whenever they need help with that. Now, when we're talking about sensory deprivation, we're talking about having problems with our ability to understand the senses around us. That would include silly things like having a hazard where we would normally not have a hazard. So an example, if you're clumsy like me, you trip over everything because you're so far into the planet Pluto with your random thoughts and processes that you forget that you actually live and breathe on Earth. So I am notorious for tripping over anything that is an uneven walkway. So this is a common home hazard for people with sensory alterations due to any type of sensory deprivation itself, or the opposite to the extreme, which would be sensory overload. So when you're hearing cars going on, you're hearing people talking and whispering, you're hearing phones go off, you're trying to teach a lecture, and you're thinking about the 15 things you need to do before you even cook dinner, things like a little tripping hazard isn't such a big deal, right? So the problem with that is when you fall and bust yourself and you're old like I am, you end up cracking a hip or you crack your head wide open. And this is why we have the big issues that we have related to our cranial nerves, because there is a disruption in how that is supposed to be received and sent down to say, hey, dummy, watch out for that, right? So this is a common issue, an anomaly with people who have autism spectrum disorder. They knock into things all the time and half the time don't even realize they've hit something. They just keep on moving because their perception of pain and their nociceptors that they have that perceive pain are dulled. So yeah, it's the most bizarre thing ever, and there's a lot to unpack with it, which is unnecessary for this class, but just so that you understand the concepts behind it. So when we're talking with people who are post-stroke and are trying to recover, we have to let them know specifically uneven crack walkways in the front door, the back door are going to be good tripping hazards for you, would cause additional issues, so we have to educate them. Extension and phone cords, I don't even know if you guys remember when you had phone cords on phones, or even landlines, or even party lines, but that's also a thing because, you know, the elderly, they still have those old modalities of doing things. things. So make sure that you let them know, hey, keep them out of the way when you're, within walking traffic. Loose rugs, I still slip over loose rugs. I slip over books that my kids have on the floor because they have hardwood floors. I slide all of the time on things, and luckily I have a good center of gravity. Otherwise, it would go really, really bad really, really quick. So for most people who are trying to learn how to walk again because they have a left-sided or right-sided deficit, we need to absolutely make sure that those are completely out of the way, or that they have that secondary padding up under that has the grip, no grip and slip type of a deal. Bathrooms without shower or tub grab bars. This is a pretty big one, but not as big as water faucets that are unmarked to designate hot and cold. So here's what happens. When you have an elderly patient with Alzheimer's dementia, obviously they're not going to have a good perception of what that looks like. So when they turn it on and then they stick their foot in, which is what, people like me do, we don't pay attention or even dip a toe in. We just, throw the whole leg until the whole thing burns, and then you kick it out, and then you just make a big fat mess and knock into other things, and then it's like a comedy hour, only it's your real life. So that's that's something that happens often. So of these, the ones I want you to focus on for sure are the ones that are italicized, because those are going to be the bigger ones that cause the greatest amount of damage in the least amount of time. Obviously unlit stairways, lack of handrails is a big deal. Poor lighting in stairways, hallways, and entrance doors also lead to slipping and tripping. So I think that pretty much covers that whole slide, and if you know those concepts, you should be good to go. All right, teaching for hearing aids. We need to do some heavy teaching for hearing aids. These things are expensive. Sorry, I have students texting me. You guys are aware. We need to make sure that hearing aids are a big deal. This fosters a lot of autonomy with our patients. They feel like a whole new person because they can finally communicate. Communication is the basis of everyone's individual identity. We need to make sure that they got this stuff understood very well. A lot of people will pull and tug at things thinking that that's going to fix the problem, and it's not, because they weren't properly educated. So we have to do that. Show them and a family member locations on the hearing aid where damage occurs frequently, right? So the ear mold, the case, the earphone, the dials, the cords, the connection plugs, things of that nature. This is important. This is the most important. Remind the client to report issues such as static or distortion of the sound immediately. Here's why. A lot of these ear mechanisms are very expensive, sometimes too expensive for a person to have, but their hearing is more important, so they go into financial debt to get these things. They also come with a policy a lot of times that states that they're good for so often, or they can get a subrogate insurance policy specifically for these devices. It's not common, but it happens often enough that these things, through wear and tear and just people not understanding how they work, will accidentally damage them, and believe it or not, a lot of nurses will damage them in the hospital setting. So we need to let them know the second you have static or distortion of sound, you need to call immediately to get them fixed. Absolute most important. Instruct the patient and the family on how to assess the integrity of the aid each day, right? Make sure that they visually inspect it, make sure that it's charging appropriately, yada, yada. Demonstrate battery replacement. A lot of people will put in a battery backwards, say that they're broken, and then never use them again, because people get frustrated easily when they know that something's wrong with them. They have to deal with the fact that something has changed. And changing in an older adult, or changing in someone with poor hearing and progressive hearing loss, it's a lot to handle. You got to think, I can't function if I can't hear, right? I can't function if I can't see. So in a lot of ways, eyes and ears are more important than fingers and toes, right? Because if I don't have the ability to communicate, what am I doing? Okay? So we've got to let them know how to do it appropriately, or how to troubleshoot the problem, right? Instruct the patient to store batteries in a dry, secure place so they don't explode and then damage the interior of that compartment within that replacement, or within that reservoir that holds that battery. Instruct the patient to clean the ear canal daily. Again, we're not sticking Q-tip squaw into the inner ear. We're not using a key like that guy from the used car lot, for the love of Pete. That was just awful. But make sure that they're cleaning their ears so that they're not putting cerumen into that area. Instruct the patient not to use hairspray or other products when the hearing aid is in place. I think that's pretty pretty self-explanatory. Let's not do anything to mess these things up. They're expensive. Review the method to check the volume. Turn dial to the maximum gain and check, is the voice clear enough? What do we need to do about it if it's not? Okay. But most importantly, remind the patient, as soon as we hear static, feedback, distortion of sound in any way, shape, form, or fashion, we've got to have them checked and we've got to have them recovered immediately. All right, so let's see. What do we have here? Areas of the brain and what they affect. Oh, yeah, this is super important. So the temporal lobe is so I look at the brain from a side view as like a boxing glove. If you look at the picture of a side profile of a brain, it would be the quote-unquote thumb would be your temporal lobe of the boxing glove. It affects hearing, smell, taste, short-term memory. All those things make sense, right? Because hearing, it's on the side of your face, yeah. Smell, yeah. So those are all basically concomitant with one another. Taste and short-term memory, well, if I stick my finger straight through your temporal lobe, you're going to hit the tongue and you're going to hit the nasal passage. If you do like a sagittal cut, which is cutting it and separating the left and right hemisphere, and then you're looking at it from the side profile. We actually had to do that in anatomy. It was a lot of fun. Let me tell you what, Cadaver Lab was something unique and something else. That's all I got to say about that. But I think now we use modern day stuff online that makes it a little bit easier, so we don't have to deal with the smells and the experiences and the PTSD that goes along with it. So it's gotten a little bit better, I think. In short-term memory, again, if I push right through the temporal lobe, you're going to run into the hippocampal area, which has to do specifically with short-term processing. Hippocampus also does long-term processing, regulation of heat, regulation of blood pressure. It does a lot of things. But the short-term memory is just slightly distal to that area. So again, if I just stick my hand through the temporal lobe, I'm going to hit all of those hot spots, which makes sense because that's what it affects. So there you go. The cerebellum is going to be in the back towards the bottom, and it coordinates voluntary movement, maintains trunk stability and equilibrium. And that makes sense because we always talk about the center of gravity, right? So you have all of your stuff up top. You got your frontal lobe in the front, you got your parietal lobe. Beyond that, your temporal lobe's to the side, your occipital lobe is in the very, very back, and slightly below all of that stuff is going to be your cerebellum, which makes sense because it hangs on to your spinal cord, right? So that's that little area there kind of hanging out with the brainstem area, and they're like buddies, right? They're like dapping each other, like, hey, how you doing today? Boop, little dap. So it's important because if I am attached to the spinal column, then that would make sure that I would have that center of gravity that I need in order to have that trunk stability, right? Because you can't have a stable trunk if you don't have a spinal column that is keeping you straight up, right? Make sense? There you go. There's your tie to all of it. So cerebellum actually kind of sounds like equilibrium in its own weird way, and it also has to do with trunk stability, and they hang out with each other and touch each other and say, hey, what's up, man? How you doing? The cerebrum, that is going to affect your impaired judgment. That's in the anterior frontal lobe, and altered temperature regulation is in the hypothalamus. I think I said hippocampus earlier. I meant hypothalamus, but your hippocampus is your memory, specifically your long-term memory. They always say that the elephant has a very huge hippocampus, which is why they have an innate memory and why they have so many troubles when they go from their home area to a zoo, because they tend to fight off whatever they had to experience when they got pulled from that area and moved into a different environment. So elephants are incredibly intelligent. So say I have an elephant brain, I have an elephant hippocampus. There you go. And then, of course, the brainstem affects your ability to swallow, which is going to directly affect your ability to breathe, because if you're not swallowing, it's dumping into your lungs and then you're going to die. Okay, so cranial nerve 3 is ocular motor. We need to check for the pupillary constriction accommodation, and they will constrict with near vision. So in order to test that, you need to shine a light in the pupil of the first eye, look for ipsilateral constriction, which is same side. and the contralateral, which is opposite side. And note the size and the shape of the pupils. The optic nerve, if it's not intact, you're not going to get a reflex period. So cranial nerve 7 is the facial nerve, and we need to get them to raise their eyebrows, close their eyes really, really tight, purse their lips, draw back in the corners of their mouth, and do an exaggerated smile and a frown. And any asymmetry is going to let us know that there's damage to the nerve, and this is potentiation for nerve damage via a stroke a lot of times. Cranial nerve 1 is olfactory, which is sense of smell. So you want to close one nostril, identify an easily recognizable odor like coffee or something citric. Cranial nerve 5 is, of course, trigeminal. So lightly touch the cornea with a cotton wisp. Yes, I said lightly touch the cornea with a cotton wisp. We do these things. I know it sounds awful, but that's what we have to do when we're checking for things like brain death. This is part of looking to see if we have things like a gag reflex, to see if we have, this corneal retraction that we're supposed to have. You're supposed to get a normal blink reaction of both sides, because obviously if something's coming towards your eye, it's going to be your natural reaction to blink. And if we have a person who has a traumatic brain injury, maybe they had a car accident and they're trying to see if they're going to be, a candidate for organ donation. This would be some of the standardized tests that we do and some that I've done in the past. And it's quite terrible and awful. But it needs to be done so that we can then look at the family and go, hey, listen, there's absolutely no shadow of a doubt. We're going to have to do this. There's no way around it. They are not going to be able to survive on their own. And then that's when we talk about things like organ procurement with the different life support systems that they have and organ donation centers that they have within the region. Let's see, optic nerve is going to be 2. So you sit across from them and then have them look directly at the bridge of your nose and indicate when you move a pencil tip or wiggle a finger or whatever that is during the field of gaze that's seen. All right, so when we have sensory alteration assessments and we are older, we're going to have problem with night vision. It becomes impaired as aging eyes, move on about the time frame of months and years and so on and so forth. They lose the ability to distinguish high-pitched noises and consonants, not constants. Apparently I have lost the ability to say things properly. And then your sense of smell and taste are also decreased with aging. Specific to older adults and losing their ability to distinguishing high-pitched noises and consonants. So I may or may not have been a little bit of a jerk in school. And I had an older teacher who talked about this. So I decided to make a high-pitched frequency that said a very bad word. And I played it for the entire class at a very, very low tone. And my nursing instructor never caught it, but the entire class habitually laughed for 2.5 hours, and she couldn't figure out why. And I don't think she ever did figure it out. So that's actually a thing. Don't you do that to me. My ears are still perfectly fine. Just letting you know. So night vision is always going to be a problem. You will lose your high-pitched noises and your ability to distinguish consonants, which is why you always say or hear older people go, why are you mumbling, right? And then loss of smell and taste are also decreased with aging. And that's all you need to know for this slide. Okay, so priorities of oxygenation. From an acute care perspective, we need to always maintain a patent airway, right? It's the ABCs. It's the highest priority in order to promote and improve the patient's tolerance to do most things. Remember, whenever we're eating, just the act of eating requires a lot of exercise tolerance because most COPDers that eat, we have to give them small little tiny snacks, 6 to 8 of them, and it's because we can't power through being able to take those breaths in between. So we have to do, quick foods that, slide down easy, don't require a whole bunch of energy energy expenditure. And we need to teach them to conserve their energy by way of, these small snacks. Sorry, I'm trying to eat too while I'm trying to talk and having trouble breathing in between it myself. So there you go. So we need to make sure that we have a patent airway. It's an immediate problem. It is always going to be your prioritization issue. The patient's level, as it improves, their activity intolerance or their activity tolerance increases, which is pretty self-explanatory. The most effective way that we maintain a patent airway is coughing and deep breathing exercises. Okay, so deep breathing exercises with coughing. It's the most effective way for whenever we need to have a spontaneous cough, or we have a spontaneous cough that isn't working well enough, right? So when we have patients with pneumonia, like a couple of slides ago, we want them to clear that. So we have them do a deep breathe, do a cough, do it again. A series of 3 is usually what clears it all out, so that they maintain that patency in that airway. We need to physically encourage the client to cough and deep breathe to remove any secretions, right? This is the easiest way we do it. So to move secretions, we want them to also increase their fluid intake. Now, is this for everybody? No. If you get a CHF patient that's in exacerbation, this is a terrible day. If you have a COPD patient, genius idea, okay? Interventions basically are loosely based around removing the pulmonary secretions, repositioning, suctioning. Percussion's not listed here, but percussion's another way. We have what's called jiggle jackets for people with muscular dystrophy, or for people who have cerebral palsy or cystic fibrosis. All those guys have problems with secretions because their ability for them to have proper muscle movement, to be able to squeeze things out, is all but nil, right? There's nothing there. So we do a jiggle jacket, which is literally a vest that they wear that is attached to a machine via percussion, and it shakes them, all right? So what's the off-putting part about this? Well, nothing really. Just make sure that you don't have their electrodes on, because it's going to say their heart rate's 200. And there's going to be the occasional nurse that walks by, sees their heart rate's 200, and they're going to go running into the room, and respiratory is going to look at them like they're silly, right? Because that's what's causing them to have that quote-unquote heart rate. It's not really the heart rate. It's the vibrational pattern that those electrodes are picking up. So make sure that you help maintain a clear airway. That's always a priority. So they can get appropriate lung expansion and gas exchange. Make sure you raise the head of the bed so they can remove secretions. Remember, a couple slides ago we talked about laying down flat, and how if you have a slight cough or seasonal allergies, that's a terrible idea, because all it does is bounces up and down, up and down, up and down. Same concept. So that would be your prioritization of oxygenation, is making sure that the most effective method and technique for maintaining a patent airway is the idea of deep breathing and coughing exercises, and encouraging them to do that, as well as all of these other modalities to help with either thinning out the secretions, removing the secretions, or getting them mobile. Okay, so gerontologic effects on the respiratory system. So problems with age-related changes regarding the respiratory system, we're going to have decreased chest wall movement, and that has to do with both immobility, and as you age and as you go into retirement, you don't want to move around so much. You want to just enjoy and chill, and not do all the things that beat our bodies down as we were a lot younger. Decreased deep breathing, because it's not something that we require, because we're not overexerting ourselves. So when we are overexerting ourselves, we do require those deep breaths. And then obviously when we're kind of a little more relaxed, we don't have the necessity to do that. Well, over time, again, this whole body is an idea of muscle movement and necessitating the muscle movement. And if we're not necessitating it, it's going to get weak. So we have to keep eye on that. Decreased cough effectiveness. This one's italicized because this is a really, really tough one. So if we have decreased cough effectiveness as an age-related respiratory change in the elderly, it's a problem because we're not going to be able to clear secretions. So if we get something like a pneumonia, right, is because we can't knock anything off. We're laying around. We're kind of in an immobile state, but not quite. If we're not doing the things we normally do, the lungs recognize that. They'll catch up to that, right? So we end up brewing an infection, getting pneumonia. And as a result of that, we can't clear it. We can't get all of that stuff out and hack it out, which causes a really big issue with things like patency. We get sicker quicker at that point. So decreased cough effectiveness is normally seen as a big problem and a big barrier to getting better and being able to recover faster if we have the inability to effectively cough because we have a decreased mechanism. Make sure you guys understand that piece. Decreased breath sounds as well, which is going to go along with decreased chest wall movement and decreased deep breathing. Decreased secretion clearance. Again, this ties right back into decreased cough effectiveness. And thickened mucus. So if things just kind of settle down at the carina, which is the area of bifurcation where it splits in half like a Y site between the left and the right lung, thickened mucus that sits right there occludes an area. It encourages the inverse or the opposite of patency, right? So we are effectively making it more difficult to keep a clean airway because things are in the way, and the thicker it is, the harder it is to get it out of the way of where it's not supposed to be. So again, comes back to decreased cough effectiveness, because if you can't cough, you can't move thickened mucus. You can't really drink a whole lot either because it's taken a lot out of you, just the act of drinking itself, because of the energy expenditure you have. So it's like this vicious cycle that just habituates and doesn't get any better. It just gets worse until the patient finally gets so sick that they end up bedridden and they pass. So we need to make sure that we take heed and take note whenever we have an elderly patient, because they are going to have decreased cough effectiveness, and pneumonia usually gets them pretty quick. All right, so the SpO2 is what we're normally familiar with, and it's usually on a pulse ox. It lets us know the percentage of oxygen in the blood, right? So normal is 94 and higher. An SpO2 value below 85 is moderate to severe hypoxemia, which in a couple of minutes will start to make you confused, followed by going into acute respiratory failure and eventually comatose, or a state of being comatose, and death if it persists and goes lower, which is normally what happens, right? You don't just sit at a level of degradation at 84 or 85% and just kick it there, right? That's not a thing. Usually when you start to do that, you exacerbate and it gets worse. PaO2 is a little bit different. So it's sensitive, it's non-specific indicator of the lungs' ability to exchange gases with the atmosphere. So what does that mean? Well, I look at it as, okay, cool. Here's how I'm going to do this. Yeah, that works. Okay. Sorry, I'm thinking. I'm doing that thing that I do with my brain. So it's like making Kool-Aid. If I use 1 pack of Kool-Aid for a whole jug, it's not going to taste as good as if I use 2 packs of Kool-Aid with the whole jug, because I'm going to get more flavor. So PaO2 lets us know how much flavor we have within our lungs. That's specifically the oxygen itself with the atmosphere around us, right? So room air is FiO2 of 21. What does that mean to you? Nothing that you need to be concerned with right now, because I'm not even going to get into it. I'm just going to confuse you. This is your health assessment class. This is not Med-Surg 2. We'll get into it later, okay? So don't even stress over that. What I will tell you is a decreased PaO2 indicates impairment in gas exchange, right? And this usually signifies what they call a VQ imbalance. So it's an imbalance in your ability to properly absorb what you need to absorb in order to get the oxygenation you need to maintain homeostasis, okay? What do you need to know about this? Normal PaO2 values are 80 to 100. So if I give you a scenario and I say, what's worse, SpO2 of 80 or PaO2 of 80, you're going to know that SpO2 of 80 is worse. So it's that simple. Again, this is health assessment. This is a Med-Surg 1 or 2. Those are building blocks, and as much as I'd love to get into the pathophysiology behind all of that and articulate it to you, All I'm going to do is dance you around in circles, confuse you, and you're going to hate life. And that's not what I'm here for. So let's go ahead and get those two concepts about what normal SpO2 and PaO2 levels are, understand the basics of it, and then move on. Okay. Questions to include in neurological assessment. Now, neurological assessment is different from a cardiac assessment, which is different from, a limb assessment, right? Which is different from a bowel assessment. So neurological assessments questions are going to include, do you have blackouts or loss of memory? Are you weak anywhere? Are you numb or tingly in any of your extremities, right? Do you have headaches, especially new ones? That's going to be an indicator of hypertension. That's going to be an indicator of a potential meningioma or glioblastoma, right? Those are usually the first thing that happens to you is when you have a tumor in your brain, you get a headache, followed by irritability, followed by seizure, followed by, it's there. There's not a whole heck of a lot we can do, or let's go ahead and have it surgically removed, right? Orientation to person, place, time, and situation. Those are all neurological assessment questions. So specifically, we would ask the patient, have you had any numbness or tingling in your extremities? And that's basically what a neurological assessment is there for. It gives us a determination of what's happening to your body system specific to your brain and the connection from your brain to the rest of your body. A lot of times when we have numbness and tingling, it is a neurological issue specifically, right? Because those nociceptors, those pain receptors in your brain are sending signals saying something's wrong with this area. And that is the brain's defense mechanism for when you are not recognizing that something is wrong with your body. It is your body's alarm system to say, wake up, pay attention, something's not right. And that's how we usually communicate in the initial. As it progresses, we start to do other things to your body before we completely shut it down, and then you die. So that's kind of why neurological is such a big piece and a big player, because neurological assessments, they cover a lot of ground, right? Our brain functions and determines the functionality of our own entire body system, right? Everyone thinks cardiac's most important. It's not. Neuro is the most important. So please understand, these are the things that we look for specific to neuro and neuro only. There might be a scenario where you have to look at this and they're going to give you items to pick which one is going to be related to a neurological assessment. And I need for you to know that, have you had problems controlling your blood pressure would not be one of those things, because it's got nothing to do with neuro, it's cardiac. Or how many bowel movements have you had in the week? Yep, that's a bowel assessment. That's not a neurological assessment. So there you go. That's that slide, and let's move on. All right, so I'm going to take a minute to pause for this, because there are some people that I've had questions from this week, and they're great questions, by the way, so thank you for giving me feedback, where they want me to explain a little bit more in depth about CO2 gas exchange or retention and what that has to do with retaining the CO2 versus excitation of your respiratory system and expelling too much of it. So here's kind of how this works. So as we breathe in, our lungs expand. As we go, they deflate, okay? So as we're inhaling, we are getting a nice big breath. And within that big breath, we have all that we need, to include oxygen, carbon dioxide, et cetera, et cetera. As we exhale, we are pushing out that carbon dioxide. So here's the theory, and here's how this works. If I have an elevated respiratory rate due to pain, or due to anxiety, or due to hyperventilation from an asthma attack, or hyperventilation from anaphylaxis, okay? What I'm going to do is I am not going to be able to expel all that CO2, or I'm going to expel too much of that CO2. Sorry, I'm hyperventilating. I'm going to be expelling so much CO2 that I'm going to have improper gas exchange. So I'm going to be in a respiratory alkalotic state, right? Because all that CO2 is gone. CO2 is a positive charge, and positive charges in your body are considered to be acidic, okay? So here's excitation of respiratory rate. If you do that long enough, you're going to get dizzy, okay? Because at that point, you're going into an alkalosis state. Whereas respiratory rate that is decreased due to respiratory depression from, a PCA pump, This is a good one. They get out of surgery. I've got them too much on the sauce. They're hitting their button every 5 minutes, and then their respirations are down. They are unable to kick off that CO2 exchange because they are retaining it and they don't have a big enough breath to push it out. So again, carbon dioxide is exhaled through the lungs with respirations. Respiratory rate is elevated due to pain. Therefore, I'm going to be in an alkalytic state, a respiratory alkalosis state, because I'm pushing so much CO2 out. I'm pushing all of that acid out that my body and my lung system becomes a basic system. Not basic like, hey, I'm a basic girl, like basic like base, right? So it's about acid-base balance, all right? Whereas if I'm respiratory depressed, that means I have too much acid, which is why I'm in acidosis. Okay, I hope that helps clarify things, but I need for you to know that. Specifically, respiratory rate is elevated due to pain. That's a big deal because anytime someone's got pain and they have COPD, what are we going to cause problems with? Well, we're going to have impaired gas exchange for sure, right? They're going to be panting, and in their case, they're not able to kick it off even though they're trying to because they have a 1-to-1 ratio. They have a barrel chest, remember? So we can't push that CO2 out. So in that case, because respiratory rate is elevated due to pain, I would be most concerned with CO2 retention versus I break my leg right now, I don't have COPD. I'm worried about hyperventilating and then becoming respiratory alkalytic or being in a state of respiratory alkalosis because I'm kicking off so much of that CO2 because I have the ability to have a good breath and I have ability to push it out that I'm going to be in a metabolic state in my lungs and then I'm going to pass out. So I hope that clarifies things for you a little bit better. This is going to be something that will be included that you do need to know. And what I want you to know is that what happens when it's elevated due to pain and nothing is wrong with me? What happens when it's elevated due to pain and something is wrong with me? AKA, do I have COPD or not? So I think that's all I need to give you for this slide. Okay. So earlier we talked about vesicular sounds. Now we're talking about adventitious breath sounds. So adventitious sounds refer to sounds that are heard additional from what we expect to hear, okay? So most commonly heard, crackles, ronchi, wheezes. I would include ralls with that because ralls are technically a form of a crackle. Stridor, however, it's characterized by continuous musical or crowning sound of a constant pitch. And that, I just realized, isn't really going to articulate into much if you've never heard it before. So let me physically find out what a stridor looks like. Let me give it a quick Google for stridor because I do want you guys to hear this. Stridor lung sound. Here we go. Give me just a second, guys. Oh, for the love of Pete, really?
Protecting what matters most to you.
Protecting what matters most to you at Avika. 8 more seconds. Sorry, I'm stuck with this.
Now you'll have peace of mind for his future.
Blah, blah, blah. Okay, here we go.
In this lung sound video, we're going to do the end of things.
Not my favorite sound in the world, FYI, but that's exactly what it sounds like. And this results from, this is a partial occlusion of the larynx or trachea. Now, while it sounds terribly terrifying, I'm grateful to have it because if I have some kind of airway passage, it's better than no airway passage. So these guys need immediate resolution of the obstruction. Sometimes we do emergent percussion. Sometimes we just intubate and we say, to heck with it all. Sometimes, we have to do like a mock intervention where we remove the obstruction. It just depends on what the case is. So don't get too tied up in that. Just get tied up in the fact that stridor is probably one of the scarier adventitious sounds that you're going to hear on a patient, and it's anything in addition to regular breath sounds. So that should be enough for that slide. Okay, so I'm going to talk to you about these 4 terms, which are terms that you need to know. Period, point, paragraph. So alert is what you got right here. I'm alert. I'm oriented to person, place, time, situation. I can articulate and have executive function. I can do serial additions, blah, 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 right? That's easy enough. Here's where it gets hairy, because lethargy, a person who is obtunded, and a person who is stupor are three different levels. Think of it as a spectrum, like me, right? So lethargy, or to be lethargic, means I'm very drowsy. I fall asleep between care, right? So these are the guys that are sleep apnea patients. This is a good one. So I will physically be talking to these guys, and they're going to be halfway asleep and trying to answer questions. And they still have the ability to answer questions, right? So as soon as I snap and I go, hey, buddy, real quick, they'll pop their eyes open, right? But then they'll start closing their eyes real slow. Yeah, I understand what's going on. I'm just resting my eyes. I'm just resting my eyes. This is that guy. This is lethargy. Okay, very drowsy, falling asleep in between care. Obtunded is a degree deeper than that. A degree deeper in the subconscious not reacting with refractory movement like it should. So difficult to arouse. So at this point, I'm poking you. I'm saying, hey, 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 Joe Blow, hey, tap, 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 tap. And you go, huh, what, huh, and then you fall squaw back to sleep that quick, okay? So lethargy would be looked at as very drowsy. Obtunded is what they consider difficult to arouse, but I can still do it with light touch. Now, here's where it gets weird. Obtunded goes to stupor, and by the time we hit stupor, we are incredibly difficult to arouse. These are the old itty bitties that you hear about in the hospital who are 92 years old, 5'2", and you were grinding the palm of your hand into their sternum, and they're barely even moving, okay? It is one step from comatose, where they are completely unarousable. So again, alert, just like me. Lethargic, I'm going to sleep in between care. I'm going to sleep in between answering your questions. Obtunded is difficult to arouse, but I can still go, hey, buddy, tap, tap, little shake. Okay, what's up? Stupor is I'm sternal rubbing you, and you're barely even reacting. And then comatose, which I'm not even going to list because it's pretty self-explanatory, it's completely unarousable. I got nothing in the tank. Nothing's moving. Okie dokie, here we go. Normal ABGs. So partial pressure of oxygen, the degree and consistency, and neither of those words are working. What's the word I'm looking for here? The quality, there you go, that's better. The quality or viscosity of the oxygen in the lungs that it is receiving would be considered the partial pressure. The concentration, that's the word. The concentration of that Kool-Aid is supposed to be 80 to 100 millimeters of mercury, right? Partial pressure of carbon dioxide, or PaCO2 is how you're going to see it, but really it's just CO2, is 35 to 45. Bicarb, or HCO3, is 22 to 26. Oxygen saturation is usually standard 95 to 100. I know I said 94 or above. It's 94 or above for the purposes of your book. For the purposes of blood gases, it's 95 to 100. Don't freak out about it. I'm not going to get too terribly into that one, okay? They also call it the SaO2, so just keep that in mind. Your normal pH range is 7.35 to 7.45. Lots of numbers, but how do I remember this? This is easy. Partial pressure of oxygen, passing, is a B or above. You guys know that. You're in nursing school, right? 78 or above, B or above. We're talking 2 points here. So I usually say B or above, and that means my lungs are at good capacity. Notice that my pH is 7.35 to 7.45. So my PaCO2, or my carbon dioxide, is just simply 35 to 45. Just drop the 7. Okay, that helps you out. 22 to 26 for bicarbonate. I don't really have a hack for that, if you will. I probably should, but I don't. And I'm looking at it, and I still can't find one. If you guys find one, let me know, because I'd love to use it. And so just memorize those numbers. And then, of course, oxygen sats, 95 to 100. That's pretty basic. So values below 7.35 is going to reach an acidotic state or acidosis. Values over 7.45 regarding pH is going to be alkalosis. Now, I'm going to teach you guys Rome. It's going to be a thing. Okay, I'm not going to mess with Rome right this second because this is health assessment. I've had students go, teach me Rome, teach me this, teach me that. I'd love to teach you that, but I teach 7 classes, NCLEX, HESI review, and I got a whole bunch of people who are taking their NCLEX this week, and I'm doing 2 to 3 hour rounds a piece. And then between all of that, I have my students who are Red Alert students who are really, really having a poor time in their nursing curriculum at this time for whatever reason. So I'm also subrogating for their classes, which sometimes aren't even classes that I teach, period. So I'm not going to get into that right this second, but I will for next exam. And Rome is pretty simple, so don't freak out about that either. It's going to be the basic building block to everything you're going to learn in Med-Surg 1 and Med-Surg 2, so it's really important that you follow along when we get there. But these are the basics that I need for you to know for right this second, and I need for us to just take fact and take grace in the fact that all we're going to do is just do this little bit right here. So I'm going to ask you if something is acidosis or alkalosis, because I'm going to give you a value, right? I'm going to ask you if this is within normal range, and I'm going to give you a whole bunch of levels, and you're going to need to know what level is off, okay? So just write it down on a sticky note or write it down with your Sharpie marker. Ooh, no, not Sharpie marker, dry erase marker. Put it on your bathroom window or your bathroom mirror. Sorry, I'm pretty tired right now. I'm just trying to get through this. Put it on your bathroom mirror. Put it right around your face. So I know this sounds silly. So this is what I used to do when I was in nursing school. Because I love numbers, right? It's part of the autistic brain. I would stand right into the middle of the mirror, and around the outline of my body, I would put all of these levels around. And while I was brushing my teeth in the morning, I would stand in that body area level, and I would go over my levels while I was brushing my teeth. If you do that every day, you're never going to forget them again. Bottom line, this goes with every single lab level you have. I would encourage you to do that, because once you do it 3 or 4 times, it's a done deal, okay? That's all you need for this slide. Okay, so lung sounds, inspiratory crackles at the APCs. So low-pitched bubbling sounds during inhalation of the upper lung fields. So the apices are the upper lung fields, and the bases, right, are the lower lung fields. So when you get inspiratory crackles, you're going to hear it during inspiration. When you have, they're going to be low-pitched bubbling sounds. And then, of course, if it's apices, it's going to be upper. If it's bases, it's going to be lower. All right, so expiratory crackles in the apices, what's that going to sound like? Well, it's low-pitched bubbling sounds during exhalation in the upper lung fields if it's the apices. If it's the bases, it's going to be lower-pitched bubbling sounds during nope, that's not right. It's going to be exhalation. I'm going to fix that right now in the lower lung fields. And that's all you need to know about crackles and the apices versus the bases, inspiratory versus expiratory. All right, so let's talk about tidal volume. So a tidal volume, it is the volume of air exchanged and it's inhaled and exhaled with each breath. So it's only a small portion of the total capacity of the lungs, because you have things like the amount of the air in the lungs after expiration, that would be residual volume. Inspiratory reserve is how much air that can be inhaled after a normal inspiration. Expiratory reserve is part of that. That's how much air you can exchange after normal expiration. But what I want you to know is the tidal volume and what that means to you. And know that it's only a portion of, or a small proportion of the total capacity of the lungs, but it is the amount of volume of air exchange through inhalation and exhalation. Okay, so when we're dealing with questions to include in respiratory assessment, we need to ask very, very direct questions. So the most direct question we can ever ask is, are you ever short of breath during exercise or at rest? Literally the easiest question to ask. And from there you can pinpoint, okay, fine. Do you get short of breath when you try to do the things you want to do? Do you live in a 1-story home, a 2-story home? That's going to dictate how much expenditure we're going to have, how many steps from the street to your door. Can we walk up a flight of steps without stopping, et cetera, et cetera. But remember, the most important question that we can ask is, are you ever short of breath during exercise or at rest? And that gets us right to the nitty-gritty, right to the meat and potatoes, if you will, to figure out what's going on with our patient and to find immediacy in finding resolution for that patient. Okay, left side of heart failure. So left side of heart failure is obviously an abnormal condition. It's decreased function of the left ventricle. If it's significant enough, the blood is ejected from the left ventricle it decreases the cardiac output, basically. So you're going to be fatigued. You're going to have breathlessness. You're going to be dizzy. You're going to be confused. You're going to have a progression of the disease. And then the blood begins to pull to the pulmonary circulation, causing that pulmonary congestion. So what's the most standard clinical finding? Crackles in the bases of the lungs on auscultation. Okay? You also get hypoxia, shortness of breath on exertion, cough, paroxysmal nocturnal dyspnea. With right-sided heart failure, you're going to get things like jugular vein distension. You're going to get the swollen ankles. Those are the classic signs of that. And that's because at that point, we're into our reserves, right? We have filled so much fluid that it's got nowhere else to go, so now we're third spacing. And we're having this natural fluidity within our ankles, our legs, sometimes our scrotum if it gets to be too much of a deal, although scrotal is more related to ascites-related issues, but also heart failure. So you just have to be really careful with that. Specific to left heart failure, though, the most common sign is crackles in the bases of the lungs on auscultation. So there you go. Okay, my favorite slide in the whole wide world, which is the basis of everything around us, right? Parasympathetic versus sympathetic nervous system. So I have beaten this like a dead horse. So I'm going to go through this really, really fast because we know the bear in the woods is chasing us is going to be your sympathetic nervous system response versus I'm drinking a Mai Tai on the beach and I'm in Jamaica and life is peachy. That would be your parasympathetic nervous system response. So if I am being chased by a bear and I've just fallen into a vat of honey and the bees are coming after me because they're mad, I'm going to have dilated pupils so that I don't run into things. I'm going to have decreased saliva production because I don't have time to swallow. I'm going to have dilated bronchioles because I need to breathe really, really well. So those need to dilate and burst out for me so I can get the best breath I can so I can run. Increased heart rate and increased muscle contraction so that I can get the heck out of there, right? Increased epinephrine and norepinephrine release. I need a jolt. I need some epi. I need to get going. I need that adrenaline, right? Increased glucose release because I'm using a whole lot of energy expenditure trying to run the heck out of there, which is why when we exercise, we always have to have an extra snack, remember? All right, so decreased urinary output. I don't have time to pee. Decreased GI paralysis or paracelsus. I don't have time to poop. I don't have time to sit and squat. I'm dying, right? Decreased pancreatic secretions. I don't have time to play the insulin game. It's not time for that. Whereas with the parasympathetic nervous system process, we have pupillary constriction because we're happy, increased salivation because we're allowed to tell ourselves that we're hungry via the ghrelin, which makes us growl, which tells us we're hungry, versus the leptin, which says, leave me alone. I am in the sympathetic nervous system process, right? Constricted bronchi gives us our baseline, decreased heart rate, decreased heart muscle contraction, increased urinary output and peristalsis, and, you're happy about life, and I'm just going to leave it at that. So there is that slide in 1 minute and 55 seconds. All right, regarding hypoxia is inadequate tissue oxygenation at the cellular level. And when I say cellular level, it's because of decreased hemoglobin levels normally. It's the most common cause. Know that. It's really important. So think of the lazy river. I'm in the lazy river and I'm on a donut. And I am sitting in that donut. Me sitting in that donut going down the lazy river is exactly what your bloodstream is doing, and you would represent the hemoglobin and the oxygen binding capacity that produces oxygen to the body, to the brain, to everything, right? So when you have hypoxia and you don't have those hemoglobin stores, you just got a bunch of donuts but nobody's sitting on them, that is why you have that deficiency in oxygen delivery from a cellular level, which is absolutely a life-threatening condition. So please understand that concept that it isn't the oxygen that's the issue, it is the hypoxia from the decreased hemoglobin level that's causing your deoxygenation. So there are a ton of factors that affect oxygenation. Developmentally, infants and toddlers, higher risk for upper respiratory infections, especially when they got moms and dads that smoke around them. Infants and toddlers, also airway obstruction because of smaller airways, their tendency to throw things in their mouth they're not supposed to. With school-age children, adolescents have respiratory infections. They have cigarette and secondhand smoking, also experimenting with vapes and things of that nature. Young and middle age are exposed to cardiopulmonary issues like unhealthy diets, exercise stress, prescription drugs, illegal substances, smoking, obviously. Things like no-dose will also throw off the system. Because we are introducing a lot of caffeinated stuff, which is going to change your oxygenation factors. We need to reduce them to make sure that we're keeping them out of risk for these issues. Now, age-related changes to the thorax from ossification, decreased space in between the vertebrae is also going to affect that. Respiratory muscle strength, things of that nature. A lot of people have degenerative diseases in utero. Like multiple sclerosis, what's another one? Cystic fibrosis, things of that nature. Lifestyle factors, risk factor modification needs to be taken care of, smoking cessation, weight reduction, low cholesterol, all the things. The most important thing that we take at home away from all this is that a person with a sedentary job where they sit on their tail like I've been doing for the last billion hours, it feels like, who is constantly chain smoking, highest risk for impaired oxygenation. So long as you got that, you're good to go. Now, cerebral spinal fluid assessment. Sometimes we have to tap these guys because we don't know if they have meningitis. We don't know what's going on with them. So we'll do a spinal tap. It's usually done in the lumbar spine, and we get into, we go through in between the spaces of the vertebrae. We tap and we feel a pop. And that pop is when we're getting into that area of cerebral spinal fluid. We extract the fluid. It should be clear and colorless. And when we do our studies, they should look like this. Now, am I going to get you and expect you to know these things? No. Here's what I want you to know. Clear and colorless is good. If it's anything cloudy, we got a problem. Clear and colorless is good. If it's anything cloudy, something ain't right. Something's wrong with your white cells. Something's wrong with something, right? This is, when we see cloudy, we all look at each other like, oh God, here goes. Because it could be anything from cancer to infection. It could be, like I said, meningococcal related. Whenever we see cloudy, that is a big problem. So as long as you got that figured out, you should be good to go. So we're dealing with effects of aging on the nervous system. We're going to have age-related changes to the nervous system. There's a ton of them. There's probably 30 of them if I'm honest. But the ones I want you to know about are the most important ones, which is altered balance. This is usually a result of cochlear nerve, cranial nerve 8, the vestibular cochlear nerve. Obviously, as you age, things deaden, right? Things become so used to working that they start to deteriorate over time. So your balance is going to be off, which is why people trip and fall a lot. Vertigo is another reason for this. Again, this is a problem with cranial nerve 8, vestibular cochlear. Syncope. The idea of syncope is when you stand up, your systolic pressure drops rapidly. And it's because your body doesn't have enough time to catch up with your heart and it trying to pump effectively. So when you stand too fast and you're older, and things are running a little bit slower because you've been running your whole entire life and that heart's been pumping its whole entire life on point like it's supposed to. If you stand all of a sudden, it kind of thumps the heart and says, move, move, move. And the heart goes, but I don't want to, I'm so tired, right? And you get this episode of syncope where your heart doesn't catch up to the circulation that you were required to have at that point. So you get dizzy and you fall. Increased postural hypotension, same diff, same process. Now, you'll notice increased systolic pressure. So the idea behind increased systolic pressure as you age is very simple. I have worn and torn and striated, and I have thickened that arterial wall. And as I'm doing that, I am decreasing the level of dilation that I'm able to do. When we're young and vibrant, our tissues are nice and malleable. They're pliable. They can bounce up and down, in and out. They can dilate, vasoconstrict, and they do it with fluid motion. Now, as you get older, things get stiffer, which is why 90-year-old people generally can't do the splits, right? Same concept. So increased systolic pressure is because that vasodilation and vasoconstriction, that snap, 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 snap that you have with your heartbeat isn't as possible because it's tired, it's worn out, it's been beaten up its entire existence. And what happens is when you don't have the ability to vasodilate so well, you basically kind of lock up. So you have to have increased systolic blood pressure to get that blood flow circulating throughout your body to feed your body and to supply it with oxygen and blood like it needs. So the biggest deal here, even though we have all of these other nervous system issues, is the increase in systolic pressure, because that is nearly 100% the case around the gambit of people aging, specific to nervous system function. So let's talk about visual deficit behaviors. When you see that someone's poorly coordinated, they're squinting, they're underreaching or overreaching objects and not quite getting them, they're constantly repositioning things, they have night vision impairment, they're falling, you should be really leery of the fact that someone has a visual deficit, specifically when you had a recent fall. It should definitely raise that kind of suspicion. So very simply put, if we're concerned that a patient might have a visual deficit, we look at them and we go, when's the last time you had your vision checked? Right? This is going to give us a lot of answers to a lot of questions very quickly. And a lot of times they're going to do a couple of things. They're either going to go, it's been a little bit, which is an indicator for it's been a long time. Or they'll let you know, hey, I just had it recently checked and you know you're okay, and you'll get, what that optic institution is, so you can give them a call and see if you can verify. Or they'll get angry, and usually if they get angry, it hasn't been checked in quite some time. So they'll give you a direct indicator to let you know what that looks like, and that's going to give us a direct flag to start paving the way towards getting that resolution, so that we can get them corrective lenses so that they don't have these issues later on. Impaired night vision, that's going to be a thing regardless, but at least we're not going to be overreaching, underreaching, squinting, having poor coordination, and things of that sort. Okay, so tinnitus, just so we understand the differences, it's characterized constant ringing or buzzing sound in the ear, without an external source. A good way of testing this theory, if you have a patient that doesn't really know what tinnitus is and doesn't really understand what's going on, ask them if they have to turn music or a TV on while they sleep. A lot of times people will do this because they're trying to drown out the sound of the ringing in the ears. It is occurring with sensorineural hearing loss or cerumen impaction or earwax and infection sometimes. Also ototoxicity from medication, specifically Lasix. You will need to know that in the future, so don't ever forget that one. Pruritus is nothing more than itching or burning. It's caused with infection a lot of times. Otalgia, it is pain in the ear, usually from a direct ear disease. And then presbycusis, like we talked about before, is gradual onset of high-frequency hearing loss from just basic aging. So please understand those terms. Okay, finally, this is the last one. I'm so glad it's over. This is a pretty long video. It's 120 minutes. This is probably the longest one I think I've done in a while, and this 120 minutes has taken me all daggone day between all the other calls I've gotten and all the other issues that's gone on with the day, so it is what it is. There's going to be plenty of time for you guys to go over this. You guys are going to do 100% fantastic. This is absolutely going to be the better way of me doing this, and now that I know it's going to take me about 40 hours to do this, which I did not anticipate, I will start doing this much earlier so that you guys aren't freaking out because you only have 3 days to study, which, trust me, when you get through it, it's going to be far more than what you need. It's always scary when we do something new, so everyone kind of gets a little nervous, and that's fine. I get that. It is currently nearly 11 o'clock at night, so I'm going to shout these over to you as fast as I can. And I appreciate your patience, and I appreciate all your encouragement and understanding that when students call me and there's an emergency and I need to go run to it, that you guys give me grace. I really am appreciative of all of you. So eye examinations, I'm just going to conclude with this very quickly. This is a list of all of your eye examinations that you need to know. You need to know that things like a Jaeger test is used to test visual acuity, right? You need to know that gaze positions are used to test oculomotor function and cranial nerves 3, 4, and 6, right? Simple things. So as long as you got this, you've got everything. You have everything that you need from the entire slideshow. And I'm proud of you. I love you all. I know that that's a crazy thing to tell people that you barely know, but you know what? I respect the fact that you're here. I respect the fact that you work as hard as you do. I see you working as hard as you do. I know you work multiple jobs. I know you're single parents. I know that you guys have gone through tragedy and you've turned tragedy into triumph. And I recognize that and I love that about you, which means I love you, because to not love you is to not love myself. And who's going to do that, right? We're all connected. We all need to support one another. We all need to be there for one another, even if we don't necessarily have the time. We want to give people encouragement. We want to be a light for each other. And you know what? I see it every day and it makes me so happy on the inside, and it makes me happy to do what I'm doing here. So stay focused. Go through the slideshow. If you see anything that looks different when you're reading the slides and you go, that's not exactly the way it's supposed to be, those aren't regular, there's something italicized about that, I want you to focus on those hot spots. If you need to look at your supplementary slides, they're in there as well in the week that you're going to be studying. So just go to your modules, and if you need to look at those supplementary slides, they're in there. They've been in there. Obviously, read your book, do all the things that you need to do, follow the recipe, and your chicken's going to be dynamite. So I'm going to go home. I'm excited to go home. And you guys are going to do a fantastic job come Friday. And again, I love you and I'm proud of you. And if you need me, call me. I'm here. All right, guys. We'll see ya.